got a lot of other questions to ask you, but we'll wait till the
Okay.
discussion session.
Did you get your stuff fixed, Dave?
Yeah,
Okay.
we're going to have Dr. Adams tell us about what we've been talking about all morning, the arrhythmogenic mitral valve disease, and its causes and treatments. And
Jimmy, you got the clicker, buddy?
oh yeah,
Oh, yes, sorry.
Let me borrow that thing. So
don't shake it.
this is perfect to follow this up from the case that Michael presented this morning. I was just going to give a very quick summary in 10 minutes because we don't have time to really cover the whole topic, but it's so interesting. And I'll start with this. Can you just go back one slide, please? Yeah, okay. So I'll start with this and remind you guys that we're so used to thinking about the ventricle affecting the mitral valve. Ventricle dilates, mitral valve leaks, but we have not talked a lot about how mitral valve anatomy can affect the ventricle and volume loading, by the way. There's a combination of things. It can't just be anatomy. It's got to be also volume. And think about this picture. Which sail creates the tension? It's the big sail. By the way, we've been going through our NIH grant with this theory for a long time. I'm not sure it's a little more complicated than this, but let's start with the idea that big leaflets are worse. And of course, we'll go back to John Barlow's original description of prolapse that predated echocardiography. The original patients he described had ventricular ectopy. So from the very beginning of mitral valve disease, we've known ventricular ectopy is part of the syndrome. And it really sort of started to gain momentum about 10 years ago. This was a paper from the Mayo Clinic in their sudden death clinic. To get in the clinic, you would survive sudden death in the field and came in. That's kind of a strong strong way to get in. And the phenotype kept emerging. I've skipped some of the early literature just for the sake of time, but it's young patients. They typically have bileaflet prolapse. Most are females. Most have PVCs. Many are identified from the posterior papillary muscle region, and they do have these infarct patterns. So there is clearly a phenotype of this, and this really, Christian Basso really deserves a lot of credit because this paper probably put the next exclamation point on it. First, she did it in the autopsy suite where she looked at patients that had had sudden death and found this disjunction, Barlow's, and fibrosis. And Jimmy, you're right, it's not just papillary muscles, it's more in the ventricle than it is in the papillary muscle. And then she did something very interesting. She also said, let's look at living patients and we'll do MRIs. And lo and behold, the patients that had ectopy also had positive MRI enhancement. They were the patients that were getting scar. So as usual, if you want to really think you've discovered something new, go back and look in the literature. It's all there from way back when Barlow was. And now this Pado group, maybe to a detriment this time, they now looked at patients that had mitral annular disjunction. This created a lot of, I think, misunderstanding because, of course, MAD is part of a bileaflet syndrome. Not everybody, as Tirone pointed out today, has mitral annular disjunction, but lots of them do. And I think if you look at bileaflet prolapse, and that's going to be your target, then you're going to see MAD is also going to increase the amount of fibrosis in the ventricle. And we got very interested in this topic, and I don't have time to really show you how we did, although it was always goes back to patients. And we had a patient arrest when we were putting her to sleep with simple prolapse. And then we MRI'd, and she had a scar, and that really got us into the whole syndrome, or the whole thought process around this. But this review article, if you want to really get caught up, I think that we published in JACC is a very good one, and it gives you the sense of a little bit like what Jimmy was talking about earlier today, about you have substrates and you have a trigger, and then you have this transient modular effect, and that's how you end up in trouble. So you really have to have three things, and you can see the fibrosis and probably the stretch, not just from the leaflet, but from the volume. All of those things are what comes. We don't know why the female gender is more associated with it. Maybe there's also some biology to that. And then the last thing I mentioned is about this part was this, as everything has to be validated, now multiple labs started validating fibrosis. And as Jimmy points out, it's not just in the papillary muscle, it's also in the ventricular wall. And now that's very well described where you see these. One of the predominant points being posterior papillary muscle. It can happen in both, but posterior papillary muscles, The most common, I think it's closer to systole. Closure starts at the posterior papillary muscle. Inlet is on the anterior papillary muscle, probably why it's more common there. And let me be clear, this is well known in the EP literature. They can identify PVCs locations, including the wall or the papillary muscle, based solely on morphology of the EKG. This is well published, practiced every day. We never make these decisions without the same electrophysiologist, Mark Miller, about what we may do or not do in terms of arrhythmias, but you can definitely notice PVC morphology not only in the wall or in the papillary muscle, but also in the aortic mitral curtain. So you really have to have an electrophysiologist that really knows this stuff working with you, I think, to get into this space responsibly. As Tirone said, caring about a patient means knowing what you don't know, and you can't do this without an electrophysiologist. Let me show you a quick patient, C72, frequent PVCs, a good ventricle. She has an ectopic burden of 27%. So this was one of the patients sort of in our earlier experience. We've probably done eight or 10 cases by now, but now we're looking at someone that's got bi-leaf foot prolapse, or not bi-leaf foot prolapse, she's got tall leaflets and they are moving, and you can see in the commissural view how they come up. They sort of have this cauliflower appearance. And here's her rhythm strip, and actually she has two locations. She has one in the outflow tract, she has one in the papillary muscle. So these two PVCs are basically being linked to different places. And here's the dominant one was in the LV outflow tract. I'll talk about hybrid PET in a minute, but we started to do hybrid PET MRI as part of our sort of research journey in these patients. And in this particular patient, you can see that her predominant place that she has that lights up with FTG is in the LV summit, and then a secondary one in the posterior papillary muscle. She has high PVC burdens with triplets, and this was the anatomy of the valve. You almost, I don't want to say you can almost see the fibrosis, but you feel like you can when you look at some of these papillary muscles. But just like you saw this morning, and we won't really show this video for the sake of time, other than to show you when you do, maybe we need to just to show you both. So we're going to isolate the papillary muscles in this case. We go right at the base, Jimmy. It probably creates a little bit of a lesion around the base of it and the papillary muscle as well. And it usually takes 2 or 3 burns. We do 2 minutes to do that. And I think just for the sake of time, I'll tell you that after we finish this mitral valve repair, we then opened the aorta and did the LV summit lesion, just a single 2-minute lesion between the left and non-commissural area in the leaflet. So actually you can see it right here. So that's the mitral, and then we'll open up the aortic valve, and that's the summit lesion. So, and just to say, this is what you need to do to get in this business too. If you're going to be in this business, you got to be able to do 3-month interrogations. I think it's really mandatory because this is so new in this journey. But this particular patient, you can see the burden went to 2%. We describe that. Ahmed El Ishmaeli wrote up our initial experience with it. This is basically the summary of it right now. And I'll just point out that a lot of people ask me about PVC burden. It's got to be high. We don't do low PVC burden, 6, 8, 10. That's not the patient target. You really want to have high burdens or, as Mark Villanelle pointed out this morning, malignant arrhythmias. And then I think we do 2-minute lesions are enough. These are not very thin, they're very thick things. And most of the time, we've been very successful. We've been very happy. We're getting ready to publish our 1-year outcomes, but we've had 95% significant suppression. This was the PET MRI I mentioned. This is a big story. I think it's going to be the future of how we evaluate patients with mitral valve disease outside of the things we were talking about this morning. We got the idea that if you were having scar and fibrosis on MRIs, it's got to be preceded by something. So we started doing MRI, PET MRI. It was a research study. It wasn't reimbursed. We were actually paying for it with our own philanthropy, because we thought we would start to see 2 things: some patients with scars, some patients with inflammation. And lo and behold, that's exactly what we did. And you can see the echoes And you say, well, active surveillance, moderate MR, we're going to wait and see. And when you do the MRIs, it's quite impressive. And they don't all have bileaflet prolapse, and they're not all young women. Something's going on with mitral valve disease in terms of anatomy and in terms of stretch, and lots of patients have fibrosis and lots of patients have inflammation that are being followed under active surveillance. I think that's important. It's always great when your ideas are validated by others. In this study, I just show you because it was Michael Borger and Levine in this group. I think Joe Wu's involved in this as well, or they're involved in another animal study. But you can see the same things we're seeing in humans, Jimmy, just like you said about dogs, we're now seeing in other systems. This was a mouse model, a knockout model that got regurgitation and develops the same patterns of fibrosis that we were seeing with MRI. This paper, I just show you quickly because we also started to get interested in moderate MR. We saw a lot of patients today in the clinic we were following with moderate MR. We're seeing the same things. Patients with moderate MR get inflammation and fibrosis. So following moderate MR is not benign. There's a long way to go in terms of understanding this, but it's not benign. And patients with mild MR develop non-sustained VT, and we have intervened on many patients like this with mild MR now. So anatomy is important, regurgitation is important. I think this syndrome is important too. We mentioned this morning, I put this back in, we presented in 2024, Demos Pandis did from our group, that yes, if you have low burdens and you do mitral valve repair, the burdens get lower. So mitral valve repair alone, fixing the anatomy does change the incidence. Less so effective if you have very severe arrhythmias. So again, for lower burdens, mitral valve repair is alone enough. This is another reason that we're not doing ablations, which is still very experimental and needs more publications about it, versus low burdens where we'll just do mitral valve repair. This was a grant I mentioned. I just call out Maria Giovanni Treviera, who's the primary PI, and Mark Miller's the electrophysiologist I always work with, and Zaid Fayed runs the imaging group with us. But this was an important opportunity for us to really study this disease, because now we take patients based on anatomy, not based on arrhythmia. You get in the trial with it just on your prolapse, not on your arrhythmia, and then you can see we've added dodatate to look at macrophages in terms of patients that we're following, and we're doing endomyocardial biopsies. So now we can biopsy control samples in the heart, and we can biopsy places that are lighting up with inflammation so we can understand at the cell level what's happening. Patients that have mild disease that don't have arrhythmias, we're following them for 5 years with this PET dodatate MRI to see, is there a signal when they start to develop inflammation? And then for patients that undergo surgery, obviously, we still have this opportunity to study arrhythmias and also study ablation. I'll just show this last image here, and this is around the dodatate imaging. This is a patient that does not have malignant arrhythmia syndrome. This patient does not have arrhythmias. Look at the heart, at the cell level. This patient not only has scar, but this patient has activation, has inflammation, and has activation of macrophages. This is not a benign disease. We are very late to the game in many patients. And I think this study is going to prove that, and I'll end on this slide, that I think that in the next 5 years or 7 years, it's not going to be 1 or 2 years, in the next 7 to 10 years, we will all look back and think we were following patients with mitral regurgitation and waiting for them to develop symptoms or have their ejection fraction fall below 60. And I think we'll all realize for many patients we waited too long. And that last one at the bottom, or the one in the middle, I think, is the real story. We mentioned earlier today, and Pat brought it up, you got to monitor patients before you operate on them, particularly if they have a phenotype for potential arrhythmias or discover palpitations. I think PET MRI is a big deal, and I think the MRI is going to become part of patients under active surveillance. And if their heart lights up red, I don't think I want to be under active surveillance. And then the last thing is we'll learn more about ablation strategies. There is a subgroup that benefits. Right now we go at PVC burdens of 14%, but I don't know where that'll land. Thank you.
That is an incredibly interesting new field, MR.
Mark, we're not there yet. So that's why I said for us right now, we're just following those patients. We're not trying to ablate them, and I think it gets, and Jimmy may comment, but I think that the ablation so far at that level has not been as easy to do as what we're doing in terms of isolating the entire papillary muscle.
Yeah, this is a very interesting disease. You know, it actually, I hate to tell you how old I am, but it actually started out before echo was available in the early 90s, and it was early 70s, and it was reported. It was called the mid-systolic click, late systolic murmur syndrome, and tells you they were still using stethoscopes then, and one of the original papers that was published on this showed two patients, two females, who had what was called the mid-systolic click, late systolic murmur syndrome. Both died, sudden deaths. And so it was considered to be a lethal problem. And the echo came along, and they started echoing all these middle-aged women, and found half of them have prolapse of the mitral valve. And so they had known that these two original ones had prolapse, but not by echoes, by autopsy. And so it was originally considered to be a very dangerous problem. That's why I said my mentor, John Bueno, had it, and always thought he was going to die early, which he didn't, fortunately. But when the echo came out, the Barlow syndrome started being appreciated and so on, then they realized that there's a small percentage of people who do have that association, and that's the group we're talking about now. I think this work that you're doing on your NIH grant is very important, and it's going to ultimately probably tell us what we want to know. The strain measurements, particularly in the left ventricle that are being made now, especially left ventricular segmental strain analysis, indicates that the basal portion of the ventricle, that's actually the segments that are actually attached to the mitral annulus, are most, in my opinion, it's probably those segments that are causing the problems. Why? I think that we need to nail that down, because in addition to ablating the papillary muscles, I think those eventually are going to have to be ablated too, because they have a huge impact on mitral valve function, mitral insufficiency. Segment 4, for example, in the scheme, sits immediately beneath the lateral commissure, immediately beneath it, attached to the mitral annulus. Segment 1 sits immediately beneath the posterior commissure. And we know from some work that's being done at Northwestern now that segment 1, which is actually anterior, in the anterior base of the left ventricle, is the defective segment that is associated with long-term failure of mitral valve repairs. So maybe we need to put a commissure stitch out there, you know. So there's a lot left to be learned about this, and I think in the process we'll probably figure out exactly where this is coming from. It's clearly a tethering problem, because a parachute problem in probably most patients, because of the fact that if you fix the prolapse, it goes away. Not always, but sometimes. So it's a very interesting area.